In addition to the other folks we've already talked about in terms of quality theorists and gurus, Deming was a third person that some hospitals have adopted their principles. And I would say that really Dran and Deming are the two most common that you'll see. And Deming had 14 key points in his quality model, talking about creating a constancy of purpose so that everybody was clear what their main purpose was, making sure that you had philosophies and make sure that leadership was engaged with the regular staff. This focus of getting rid of inspection, but more building quality from the ground up, minimizing cost by improving, supply cost and the availability of things, and really getting the way to improve quality and productivity in this constant way of trying to cut waste out of care that's provided. Make sure that people are fully trained on the job. And then supervision. People should be there to help people, not to inspect. Again, drive out fear out of the organization, where many organizations had this more mindset of, you have to be working all the time and I'm watching every little thing you do. And then breaking down barriers so that everybody's really working as a team throughout the whole organization. Making sure that when you fix something, you fix the system. Stop worrying about getting a certain amount of quotas or different outputs in terms of volumes, and instead really focus on how to be a good leader, and then remove any barriers to the pride of workmanship so that it makes it very easy for employees to just be thrilled with the things that they're doing, and instituting lots and lots of education and self-improvement for different people in different jobs, and then really transforming everybody's job to one in which they feel valued and that has importance attached to it in terms of outcomes, so that people really buy into the quality as a team focus. So in addition to those three main kind of drivers of continuous quality improvement or total quality management systems, there was also a person that came up with kind of categories of how you would set up your measures in healthcare, and you would look at these in terms of I'm measuring a structure, I'm measuring a process, or I'm measuring an outcome. So I'd encourage you, as you think through measures and things that would be with your quality problem as a team, what is it that we really need to measure? Do we need to measure something that is part of the structure of care? Is it some piece in the process that constantly breaks down or is a problem? Or is it an actual overall outcome? And from there, then we would go back and see what other processes we need to measure. So, and I will say in terms of measures, we'll talk a little bit about that further on, but knowing that you broke these down into these categories kind of can help you when you're trying to think about cause and effect of a problem. What is really creating the problem? And then what do you really need to measure? Granted, you want to always measure outcomes because that's what you're really wanting to achieve. But in addition to that, you may really need to develop some other measures that tell you a little bit about upstream issues that may be occurring that have a downstream effect on the overall percentage of the outcome. So the top little outline kind of is more the hospital level looking probably in terms of structure, process, and outcome. So, that picture there talks about organizational attributes as a part of structure, physical characteristics maybe of their building, or physical characteristics of your consumers. What are the structure of your leadership and different people's responsibilities? What kind of culture have you been able, or organizational design have you created? What kind of information management system as a structure is in place that supports some of these things? And are there incentives that encourage better performance on some of these kinds of outcomes? And then in process, you look at diagnosis and the whole context of treatment, which is gigantic. Although those are two simple terms, that is a huge section there when you think about what all occurs in the processes of care. And then outcomes, whether that be service quality, morbidity, mortality, length of stay, different kinds of things that give you an idea about how well you've done care as a hospital providing care. So then if you look at the second block, this is kind of more nurse focused. What kind of characteristics of the patients maybe influence the outcome? What provider characteristics by nurse or physician, in terms of education, age, or experience, could have an output, could influence the outcomes. And then maybe unit characteristics as a nurse leader, like I have more LPNs than RNs, or not enough techs, or whatever in terms of staff mix, or even a model of care delivery that might be more effective than the one that you're currently using. And then process here is looking at assessment, monitoring, surveillance, individual nursing interventions, patient family teaching being done, coordination of care, unit workflow, space and technology, different things that occur within the process. And often in the process in hospitals, there's all these other inputs in the process that come in from different departments. Obviously, if we have made a medication error, there could be something in the line of the process from a pharmacy dispensing situation that is part of the process, but would also be that middle part of the treatment that we would have to break down to look for ways that we can improve the quality of that. And then outcomes, nurses may look at it in terms of length of stay, readmission rates, return visits to the ED, just different outcomes that they might think of more than at the higher level of thinking. I won't go into all of these, but I gave you a link for all of these. There are national repositories of performance measures that have come into place because of this huge movement over the last 15 to 20 years. And now you can pretty much go to any one of these and find data on different hospitals, different guidelines that have been utilized in hospital. Measures are being done to compare hospitals from one hospital to the next. They may be risk adjusted to look at, a larger hospital might have a better ability to achieve higher percentages because they have a much larger volume of patients that they're seeing to get consistency. But just so you know that there are lots of measures now that give information to the public, as well as that are being pooled information from a quality standpoint, where outcomes research is really looked at in terms of how we get paid in healthcare these days as well. These are some emerging models that are newer that have come out in healthcare related to quality. Some of our larger hospitals in the region have a Six Sigma training program or a lean enterprise. And so you see even in this picture here, they've got Lean Six Sigma listed kind of together, when in reality, the Lean Enterprise and Six Sigma are two separate processes, but they're very close, or two separate models, but they're kind of close. And so I just listed here kind of the basic difference. The interesting thing in Six Sigma is you get training, but depending on your role in working with quality in a healthcare organization, you get actually a literal belt that you achieve, kind of like you would if you were in Taekwondo or something like that. And so you achieve different levels of expertise in terms of your training and how many projects and how many quality problems that you've worked on in an agency. And the more you do, the more experience you get until you're, finally the ultimate level there. There is also a Malcolm Baldrige National Quality Award that is given every year that's very exclusive in hospitals, and many hospitals really want to achieve that. And then you will also hear models talking about making sure that your hospital is considered a high reliability organization. And these are some of the characteristics of a high reliability organization. There is a preoccupation with failure, so that you are constantly looking for the most little bitty errors and events that might occur as a symptom that something's wrong. So you never go, oh, well, that's just something little. Now, every single time, your management team is going to have to be really focused on digging in, what happened, what could we have done to prevent that, just really a huge focus on always looking at failures, no matter how small. And then sensitivity to operations. You're really paying attention to your front line of employees and what actually happens at the bedside. You're not in an office. You're constantly walking and managing by walking around, interacting with, your stakeholders, interacting with your personnel, interacting with your consumers. There's a reluctance to simplify. So you really want diversity in experience, perspective, and opinion. You want to be as detailed in your information about processes so that you really break them down into many, many steps, because you don't want to simplify anything. You want to know every little nuance that might have an impact somewhere. And you're very open to having as much of a diverse group of people working on things. Commitment to resilience. So you want to also, as to achieve this kind of organization, a leader needs to develop capabilities to detect, contain, and bounce back from events that do occur, so that you really have this ability, even though there's been a problem, you've got on top of it, you've handled it, you've done whatever. You don't, worry about, the backlash, except from the standpoint of fixing something so that it will not occur again, and then move right on with continuing your efforts towards being a high reliable organization. And then there is deference to expertise. So this means pushing your decision making down and around to the person with the most related knowledge and expertise. So high reliability organizations often are going to have very down in the trenches kind of committees, task forces that really involve people that really are the experts to come together to solve any kind of issue or be engaged in activities about all of those things. The ANCC also has a magnet recognition program, and we've talked a little bit about that already, so I won't bore you with that, but you will see that some in hospitals from a nursing perspective in terms of how to maintain quality or have a model for doing that. And we know that the costs associated with poor healthcare quality are lost income for the agency, lost income for affected patients, disabilities that occur because of poor care in patients, and healthcare costs continue to rise astronomically due to litigation or the cost of maintaining quality programs. And I did include this report in As You Learn, the to Errors Human if you would like to take a look at that as well.